Good afternoon, everyone. So today I'm going to present on the topic Unravelling the Enigma of Ocular Sarcoidosis. So in the first case, a 45-year-old female presented to us with the chief complaint of floaters in the right eye since 1 year. Her vision in both the eyes was 6/9 with the pinhole and not improving further. Both the eye shows cells. In the right eye, they were more as compared to the left eye. Both the eye shows vitritis, vitreous membranes, snowball, and candle wax drippings, and they were more in the right eye as compared to the left eye. This is the OCT image of both the eyes. Skin lesion just below lower eyelid noted. Investigations were done, and she is a known case of pulmonary sarcoidosis. Mantoux came out to be negative. Serum A's were on the higher levels. ESR raised, and the rest tests for uveitis were within normal limit. FNAC from skin lesion confirmed cutaneous sarcoidosis. So the diagnosis of definite ocular sarcoidosis was made. Treatment, she is on oral and the topical steroids. Over a period of 8 months, her skin lesion healed and the pulmonary symptoms also improved, but still she has recurrent vitritis. In the second case, a 30-year-old male presented to us with the chief complaint of floaters in both the eyes. His vision in both the eyes was 6/6 with the pinhole. Both the eyes showed Witt cells +2, but in the left eye, there were old KPs also present. Diagnosed elsewhere as viral parotitis, showing parotid gland enlargement. At presentation, both the eyes showed disc edema as well as candle wax strippings in the periphery. Investigations were done. Serum A's were on the higher level. Mantoux showed no induration even after 72 hours. Chest CT showed significant findings. Diagnosis of the Heford-Weldon syndrome was made, so we thought it is presumed ocular sarcoidosis. Treatment, oral and the topical steroids. Over a period of 4 months, the posterior uveitis completely resolved along with the resolution of parotitis as clearly indicated in these pictures. In the third case, a 40-year-old male presented with gradual painless diminution of vision in the left eye for past 2 weeks. His vision in the right eye was 6/6, left eye 6/12 part. On the posterior segment, right eye showed subtle subretinal yellowish lesion along the IT arcade and the nasally, whereas in the left eye it was along the posterior pole along with the SRF. These are the FFA and the ICGA finding of the corresponding patient. On the B scan, thickening at the posterior pole with the high surface reflectivity and internal variable to hypoechoic signal was present. So following DDs were made. Investigation was done. Everything was normal except serum A's were on the borderline only and the Mantoux showed no induration. Chest CT shows few sub-centimeter sized mediastinal lymph nodes. Diagnosis of query-sarcoid granuloma in a case of presumed ocular sarcoidosis was present. Treatment on the oral steroids. 4 weeks after treatment, there was complete resolution. In the fourth case, a 35-year-old male presented with blurring of vision in the left eye since 25 days. His vision in the right eye was 6/12 with pinhole and the left eye 6/24, which was not improving further. Right eye fundus completely within normal limit. Left eye shows large optic disc granuloma, basically reaching up to the optic disc and posterior pole. OCT of the left eye. FFA clearly shows late phase disc staining and the large hypofluorescent area which can be seen reaching up to the optic disc and at the posterior pole. Investigation were done. Serum A's were significantly elevated. IGRA came out to be negative. CT scan showed the significant finding. Appearance are suggestive of pulmonary sarcoidosis stage 3. Diagnosis of presumed ocular sarcoidosis was made. Treatment, oral steroids. 30 days after treatment, these show the resolution. So now comes to the discussion. Sarcoidosis is basically a systemic inflammatory disease of unknown etiology characterized by the formation of known casseting granulomas. These are basically the findings which can be seen starting from the eyelids and can reach up to optic nerve and visual pathways also. Following pictures, A shows the mutton fat KPs, B multifocal choroiditis, C perivenous shinding along with the hemorrhages, D large granuloma along IT arcade, E shows the chorioretinal lesions. This is also few of the pictures. B shows the hot disc, C few hypocyanous spots in the ICG. This is the sarcoidosis of the skin. We have the similar picture in our case. Broad raised skin lesions or plaques that can be smooth or rough and skin red or brown. These can also be seen arising from tattoos. This is the original article basically distinguishing TB granuloma from the sarcoid granuloma. Top row shows the sarcoid granuloma which are usually intense yellow, have the SRF and bigger one, whereas the bottom row shows the sarcoid granuloma which are usually small, dull yellow, rarely distinguished from the retina. This distinguish between the OCT of the TB granuloma and the sarcoid granuloma. Basically in TB granuloma there is a contact sign, RPE disruption and the outer retinal layer reflectivity is present. Whereas in the sarcoid granuloma these are usually small and there is no outer retinal hyperreflectivity and usually the RPE is intact. Evaluation can be done from the international workshop criteria. Treatment, basically corticosteroid is the mainstay. Rest, these biological agents can be given. So the conclusion is it is important for the ophthalmologist to be aware of ocular manifestation of sarcoidosis, as they may be the first sign of disease and can lead to severe complications. Thank you.
Any questions from the judges, sir?
Priksha, there are all clear-cut patients, most of them,
Yes,
and
sir.
all responded to steroids. So what is so unusual about this?
Sir, usually it means that the oral steroids, usually patients resolve. In
That
very
we
few
know,
patients,
that we-
antimetabolites are started.
That we know for times immemorial now.
Yes, sir.
Yeah. Even when we were residents, that was the clear serum ACE levels, lymph nodes, and typical presentations. You presented 4 patients.
Yes, sir.
Presentations are pretty good from documentation point of view.
Okay, sir.
But it's okay that no. But only thing is there is nothing that we become wiser after listening to these 4 cases. They're all very typical patients. First was very typical known patient of pulmonary sarcoid. Second was presumed sarcoid. The fourth was a granuloma. Granuloma point I think was interesting because that can sometimes mimic a lot of other things.
Yes.
So I think you should also highlight how you showed one slide where mimic the between tuberculosis as well as sarcoid.
Yes, sir.
So
There-
people get sometimes confused or taken aback. The reason is why I'm saying so because whether to start ATT or not in such patients, that somehow you should highlight also.
Yes, sir.
Apart from investigations of serum ACE levels and MON2 test, nowadays we have to rely on HRCT for tuberculosis also.
Yes, sir. It was done in almost every patient. Chest CT was done.
So very good.
Thank you, sir.